anesthesia and getting intubated with succinylcholine and have 3 or 4 surgeries and not develop malignant hyperthermia until the 5th surgery.
True.
Yes, exactly. True or false? There's an uncontrolled release of calcium at the cellular level inside the muscle cell. True or false? Okay, yes. So it's an uncontrolled release of calcium. That's really the underlying problem here, okay? Okay, what are some of the triggers? Tell me what are the triggers that people use to cause MH? Sucks? Yeah, but something else?
Desflurane?
Yeah, any of the volatile anesthetics, so the gases and or succinylcholine, okay? Do you have to use both to have MH develop? No. It could just be succinylcholine. Yeah. So now everybody thinks MH is very rare, which it is, but I have had at least 30 MH cases reported to me in the Tri-County area in the last 5 years, okay?
Wow.
I was just at a surgery conference 2 weeks ago, and I had 2 directors of nursing walk up to me and tell me they both had MH cases in the last 6 months. So, even though you think it might not happen, it will happen. Now, do we have OR people in here too, or just recovery?
No, this is all.
Oh, this is all OR. Okay. So, all right. So no recovery room in here. Oh, okay. So then we won't talk about a recovery room scenario. We'll talk about the OR. So let's just say you've got a 100 kilogram male coming in for hip replacement. Who's 55 years old. They decide to intubate this patient. They've used succinylcholine gas, and we start to see some changes in the vital signs. What would start to happen in that patient? Are there any anesthesia providers in here, by the way? No. Okay. So what do you think they might see with the vital signs? Just
Heart rate, sweating, EKG.
vital, heart rate. Yep. Temperature going up. Good. Maybe some rigidity, right?
Yeah.
Okay. Initially, they're never going to think MH. Okay, they're going to think the patient's dry. Let's give some volume. Patient's tachycardic. Maybe having some pain. They're going to do other things initially to try to resolve this issue. But really, what will happen is that CO2 just will not come down, even though they're trying to blow off the CO2 by increasing the respiratory rate. It won't come down. So at some point, they're going to say, you know what, Dr. So-and-so, I don't like what I'm seeing here. I'm pretty sure we have malignant hyperthermia occurring. You need to stop what you're doing, get your surgery to a controlled place, which can be tricky, because what if you're doing a prone spine case? Okay, what if it's completely open belly, so open chest, so open heart patient. So, it can get a little hairy. So what do you think the first thing your anesthesia provider is going to do when they realize it's MH?
Stop the drugs, turn off the gas.
Exactly. So that's number 1. Turn off the triggers, okay? Number 2, what do you think they're gonna do maybe as a next couple steps? Anybody? Maybe, yep, hang on to that thought. So, if you have an ET tube in the patient, exactly, aggressively hyperventilate the patient. And everything's kind of happening at once, but just for teaching purposes, we're gonna just kind of go through this methodically, okay? So now, maybe it's a CRNA in the room, maybe they've asked for, attending to come over. We wanna get help to the room. So how do you guys in the OR get help to the OR? Okay, so whatever that looks like, you alert your team to come in and help, okay? When somebody's walking in the door, what might you ask them to go get?
Nice.
The malignant hyperthermia card.
Malignant hyperthermia card, perfect. Does everybody know where this is kept?
Yes.
Okay, great. Is there a crash card in every OR, or do you need to bring, okay, so when somebody walks into the room, it's like, you go get the MH card, you go get the crash card, because you want both emergency cards in the room, because these patients can actually code too. Could be a really bad day. Okay, so now, everybody comes into the room, okay? Tachycardia is getting worse, CO2's going up, temperature's going up. You bring the card into the room, and on top of that card is this, okay? This is your protocol. You don't have to remember anything I've said today. And we can't cover every bullet here because of time, but we're gonna touch on kind of the most important things, okay? Number one, get help. That's what it says here. Actually, I don't wanna read it. Here, number one, just read the big, bold words.
Get help, get dantrolene, notify surgeon, call MH hotline.
Here we go. Anybody know where the phone number's at?
It's on the very top of the book.
Perfect. I see the phone number on the side of the card. There's also the phone number up here, okay? These bullets, one of the main things it says is start hyperventilating the patient with 100% oxygen, okay? It does talk about using activated charcoal filters, which to put on the inspiratory and expiratory limbs. I have no idea if they're in your card. Does somebody?
You can crack the card.
Okay, let's have somebody do it, because I know how to pop it, and this is your supply, so let's go ahead and pop the card, show everybody how to open it up in a quick way.
Just so everybody knows, if anybody has any questions, Lisa Boucher and Victoria Nicole
Okay.
retain this card.
So anesthesia, thank you so much for finding that quickly. So anesthesia, you know, they might want those to put onto the inspiratory, expiratory limb. Please humor me, read that last bullet right there.
Don't waste time changing the circuit.
Don't waste time changing the circuit. So go ahead and get those on the inspiratory and expiratory limb. Okay, step two, and again, all this is happening simultaneously. What did I say the weight of this patient was? 100 kilograms. Okay, step two, ladies, what does the dose say right here for giving the dantrolene?
1 milligram.
Right here.
2.5 milligrams rapidly IV.
So 2.5 milligrams per
Kilogram.
kilogram. How many kilograms did I say the patient was?
100.
100 kilograms. Okay, are you a nurse? Nurse? Come here. Help me, find the dantrolene. You're the super nurse. Just find it. I'm not gonna torture you here. Or somebody find it.
I can't see.
What am I looking for?
Looking for the dantrolene, the Ryanodex.
It's not gonna be a minute.
Medication.
There we go. And there's some kits in there. Yep. Okay, so she has found, there's how many kits in here? Two, okay. Just tell them, humor me, tell them what's inside of this kit.
Ranadex. Jesus, what does this say? Sterile water, 18 gauge needle, 5 milliliter syringe, alcohol swabs, dosing guide instructions, which are small. If you're old, you can't see.
Okay, so we don't wanna mix this one because, you know, pharmacy,
Yes,
you know, paid for that. So how do we mix it? You know, so we're looking for the instructions on how to mix it. Where would you go? Well,
Probably there.
you could go here.
It's bigger because
Yep.
this is bullshit. Can't read it.
So it says, I'll just read it to you, but each vial of the Ranadex needs to be mixed with 5 milliliters of sterile water. Just for humor me, would you mind just mixing one of these, or one of you ladies right here while we're going through this? This is not rocket science. I'm sure you've all mixed a vial of medication. This is our pretend sterile water. Don't do this. We got this from the sink. It has to be sterile water, non-bacterial static. It has to be 5 milliliters. Oh, let's look at the instructions. Thank you. Actually, I'm gonna make this even easier. Inside this folder, I noticed there are some instructions on how to mix the dantrolene with a handy-dandy chart for those that maybe are panicking and can't remember. It's, 2.5 mg per kg, and it's
There was a calculator in there I saw.
Ah,
Someone was nice.
this is good to know. And if you can't find the chart, or you've got a calculator there, but tell me, if this patient is 100 kilograms, how many vials do you mix? One. How many milligrams do you give? 250. So that'll be the entire 5 milliliters, okay? So go ahead and you can get your
Sterile water.
make-believe sterile water, non-bacterial static, which is in the bag, by the way. You'll put that 5 milliliters into the vial. Okay, so you can just pop your top. Now, what I like to suggest to everybody is, once you push the sterile water in there, leave the syringe in there. So go ahead and put it in. Leave the syringe in there and just give it a little swirl, with the syringe in there. Only for like 5 to 10 seconds. You don't have to get aggressive with shaking. Then make sure when you're pulling up, flip it over, and when you're pulling up the dantrolene, make sure your bevel of your needle is under the solution. Because if we're up here, although this doesn't look right, you're going to get air, okay? So now you're pushing, we're done, that's perfect. Thank you for demonstrating that. This is going to be rapidly pushed through the patient's IV, okay? You guys, how many IVs are probably in this patient right now? One. Okay, so somebody's walked into the room, another nurse, and you want to start another IV. Does somebody want to look to see if there's IV start kits and intrasite catheters in here so that, okay, you're doing. Okay, so right here we have found IV start kits, intrasite catheters, and everything you need to start a kit, to start an IV. Do we need to collect blood work? What has she found here? Okay, so maybe while someone is starting an IV, maybe you're filling up all these tubes, okay? And we have labels right here. You are perfect. You are absolutely perfect. Okay, so this is going on here. So now let's just say we're sinus tach in the 130s. The blood pressure's actually gone up because they're hypermetabolic and they're at 150 over 100. The CO2 is at 80. And anesthesia is there, and they're trying to bag this patient, but they can't get the CO2 down. So you'll walk in the room and you'll read number 3 for me.
Bicarbonate for metabolic acidosis, 1 to 2 milliequivalents per kilogram if blood gas values are not yet available.
So does respiratory come and get your ABG, or do you guys do
We
it?
send it off.
You send it off. So at some point here, we're calling respiratory, or you've got the ABG, you've sent it off with the respiratory therapist, but this says give it. So you're on the phone with M-House, and they'll probably tell you give it, or anesthesiologist will tell you to give it. So can you just humor me and find the sodium bicarb? Okay, it's in the crash cart. Not in this cart.
Not here, crash cart.
Perfect. So there's a good reason why we also bring the crash cart in the room, because this is a situation where you're going to be pushing sodium bicarb. So thank you. So now we know it's not there. All right. Now somebody talked about this earlier. The temperature's going up. We're now at 103.5. What do we do?
Pull them down.
Ice. IV fluids. I think I heard somebody say, where do you guys get your ice?
Right here.
Right behind you.
Okay, great. And we know we have bags. Where do we get bags to put the ice in? Oh, look at that. Right here in the drawer. Okay, so how many are we gonna fill up?
All of them.
All of them. Where are we gonna put it?
All over.
Okay, perfect. And I heard, and the cold saline I heard, where is that? Can somebody just humor me and go double check and make sure there's a bag, or do we know for sure there's a liter of cold saline in there? We did this
We
at
could also
another
get the
place.
slush machine from Cardiac and start making slush.
Okay, there you go, folks. Excellent idea. We went to the fridge yesterday at a facility and it was completely frozen, the saline. So, this is why we check. Okay, moving along here. So, patients continuing to have tachycardia. Now the blood pressure's dropped to 80 over 40. We're starting to go in the other direction. We're starting to see some PVCs. Do we want to give more dantrolene? It's been a couple minutes.
How often do you redose the dantrolene?
Oh, funny, you should ask. Okay, so
It's in there.
thank you for checking. And it wasn't frozen, right?
No, it's just 3 huge bags.
Okay, that's what M-House recommends. Keep 3 liters of saline in your refrigerator, so thanks for checking. So, M-House recommends repeating that dose, that same dose, that for this scenario, you give this every 3 to 5 minutes, okay? Remember, it's always weight-based. You guys do kids here?
Yes.
Okay, I mean, if it's a little bitty, you might just be pushing a milliliter, a half a milliliter. So you might have 3 or 4 doses here. You see what I'm saying? Okay. So every couple minutes. Now, it's really up to your anesthesia provider, the M-House expert, to decide when to redose, but the recommendation is every 3 to 5 minutes, okay? So, moving along. So we've got ice on the patients, IV fluids are going, we've pushed bicarb, we've pushed the second dose of dantrolene, okay, crisis dose was given. And we're starting to see all these PVCs, okay? And the labs haven't come back yet. Actually, they came in the room and they said that it's clotted, not clotted. What happened? Hemolyzed. The labs are hemolyzed. And we're seeing runs of VTAC. And we're worried about, what? What's this word right here? We're worried about hyperkalemia. Because as your CO2 is going up, your potassium's going up. So anesthesia is going to ask you, we can't wait, go ahead and get another set of labs, but we need to treat the hyperkalemia or this patient's going to code, okay? Here, you've been so helpful. Just read what it says under hyperkalemia.
Hyperkalemia, treat with hyperventilation, bicarbonate, glucose, insulin, calcium.
Okay.
And it gives amounts.
Exactly. So we're not going to go through the dosing of it, okay? Saving you there. But can we look for the dextrose and the insulin?
Crash cart.
Crash cart, okay, perfect. So they might ask you for that. And then calcium chloride they might ask you for also?
Crash cart.
Okay, perfect. These are the medications you're probably going to need to give, okay? And any questions so far? Helpful? Ooh, look at, I'm making good timing here. Okay, so hopefully after the second dose, the symptoms start to resolve. Based on the literature and the research, usually it's about 2 doses that need to be given, okay? How many vials were in your cart?
2.
Who else should we be calling when this is happening?
Pharmacy.
Right. What did this note say right here? You wanna?
Peds PACU and pharmacy.
Additional dantrolene
Pediatric PACU.
in the pediatric PACU and pharmacy. So, what's your biggest? What are some of the weights of your larger patients? Okay. All right. Well, let's just say we have, humor me here. Let's just say the patient is 308 pounds. 308 pounds. How many vials did you have to mix?
425 the other day.
2 vials. So my point is, you know, if you're over 100 kilograms, you're going right into 2 vials, okay? So we want to make sure we get additional dantrolene to the patient's, you know, area where they're having the event. So now we've got heart rate, CO2, temperature, rigidity, everything is now going away. We don't need to give any more dantrolene at this point. And where does this patient need to go?
ICU.
So we got to call ICU, you know, start getting that ball rolling so you can get this patient out of your OR. I know we want to get the patient out of the OR as quickly as possible, right? And then they're going to be monitored in the ICU, and we won't go into what that looks like. Whoops! But I can tell you, thank you. I can tell you that they're going to have to get additional dantrolene there every 4 to 6 hours, check their lab work, monitor their vital signs, because there's a very good chance of relapse, okay? And about a 25% chance of relapse. So that happens. So, helpful? Couple other things to think about. Number 1, once you've given dantrolene to a patient, if they were to say, let's say they go into SVT, you are not supposed to give calcium channel blockers to a patient. That's like a contraindication once they have received the dantrolene. And if they were to go into SVT, don't give a calcium channel blocker, like Cardizem or something like that. You would want to use beta blocker. Dantrolene, side effect, okay? Got to talk a little safety here now, okay? So if the patients are having an uncontrolled release of calcium at the cellular level, causing the muscle fibers to really rub and heat up and get hypermetabolic and contract, right? What do you think dantrolene does to the muscles?
Relaxes.
Them. That is your side effect profile. What the dantrolene is doing is it's pushing the calcium back into the muscle cell. That's the way it works, okay? When you're giving calcium chloride, that's extracellular versus intracellular, so don't get confused with that. But it's gonna push the calcium back into the cell. That's how this works. It's almost like a poisoning, and dantrolene's the antidote. So 1 IV's in the patient, right? Typically, at the beginning, we put in a second. Always try to put the largest you can. Anesthesia might slip in a line, right? Triple lumen or, some sort of central line. They might put in an A line when all this is happening, right? Dantrolene has a very high pH, close to Drano. Okay, so you don't want to infiltrate, the dantrolene. So that's why you always want to get another IV in. Any patient crashing, you want to get another IV in. And, I'm getting short of breath. That's kind of, how this goes. Here's a fun question. If my dad has malignant hyperthermia, what do you think the chance is that I might be susceptible to developing malignant hyperthermia? 25%, 50%, 75%, 50%. Yep. So we get a good history from people, right? That's how we help to determine if they're gonna develop malignant hyperthermia. There's some other risk factors that you might want to consider. Do you guys get histories, or has that already been done? Already been done. Okay, so we won't go there. Do you guys have any questions?
But I mean, we do ask the patients.
Okay.
We get the histories. We look at the history. So that's our responsibility. So anyone pre-op can pick it up. The OR nurses can pick it up.
Yep.
Anesthesia, of course, can pick it up. It's everybody's job.
That's great. And are our patients good historians?
No.
So they'll tell one person one thing, and they'll tell somebody else something else. And there's certain things that you could ask, hey, have you ever had high fevers after surgery? Dark urine after surgery? Ever, been in the ICU or stayed in the hospital after surgery? Did anything like that ever happen to you or a family member? You could ask things like that. And,
Do you ever have a family member die during surgery?
Did a family member die during surgery? Yes, perfect. Because these things will prompt them to be like, oh yeah, Aunt Sally, you know what I'm saying.
Just stop it.
Please.
So I know we have the kits and we do everything we can to avoid this happening, but what would happen if someone accidentally mixed dantrolene with sodium chloride instead of water?
Well, that's a good question. So I guess the short answer is I don't really know, because it was studied in a laboratory using sterile water, non-bacteriostatic. So could it possibly not work? Could it possibly not push that calcium back into that cell? It's possible. That's why we've kind of, I call this like, we've dummy proofed it here, we've put everything in here that you would need to use. But it's a great question. I get it all the time. Just use sterile water.
So the other thing to do is we have a limited amount. We have two bags or 2 vials. The initial thing to do also is let the pharmacy know this is happening. They have backup supply of Ryanodex, and I believe there's also some over in ICU. So
And I think in OB as well.
yeah, so we need their help getting more to the site of where the patient is. We don't hog it all anymore like we used to. So pharmacy is who needs to know so they can get us more. Yeah. And the insulin, I asked Victoria, the insulin is in here, PACU. We used to keep insulin in the anesthesia workroom, which now that the door has a lock on it, I'm gonna see if we're allowed to do that again, because it should be readily available, and it needs to be refrigerated.
Sometimes you have to give 3 and 4. I mean, you may need to keep doing this over and over and over and over again. When you get to about the 4th crisis dose, and you're on the phone with the hotline, they might start asking what else is going on with this patient. And then you might say, oh, we were doing a thyroidectomy. Could this be a thyroid storm? I don't know.
Serotonin syndrome too. We have a lot of
Bingo.
patients that forget taking their SSRIs and SNRIs. And ICU typically, no one's people forgot to put them on the formularies,
Yep.
and you can have a serotonin syndrome, and that dantrolene is used for that also.
Are you in my head?
Mhm.
Yes.
I love it. That's exactly the point.
It's a board question for NPs.
Okay. Yeah. Antipsychotic, if they're on a bunch of
Antipsychotics is a big
antipsychotics.
thing.
Yeah, exactly. Really, thank you for bringing that up. So
Yeah.
they do have to start thinking about some other differential diagnoses. Now, I said this is a skeletal muscle disorder, right? And do you get some younger folks here having some orthopedic cases that are muscular? Or not so much?
Yeah.
Yeah, so, just think about this. So, if it's a younger person, a lot of muscle, this could really be a fulminant, jump up, slap you in the face kind of presentation. The more muscle there is, the worse this could be, and maybe the more dantrolene you would need to give, okay? I had a case in Broward County, and this patient actually was an patient having open heart surgery. You guys do that here, right? And he ended up needing, they had to use all the dantrolene in the entire health system, okay? Initially, they used everything in the hospital, but then over the course of literally the next week, they had to grab it from every single hospital. So, because he kept relapsing. So, that's a little bit atypical, but, just something to think about. Had another case down the road here, it's not too far away. It was a kid kicked in the mouth by a horse. The oral maxillary surgeon was actually doing the repair, and this kid developed malignant hyperthermia, and they recognized it quickly. They had the old formulation of dantrolene, which some of you might remember. Yep. You have to mix up like 13 bottles with 60 milliliters to get to one of these, 5 milliliters. Anyways, the very first 60 milliliters they pushed in the kid, the IV infiltrated. Wasn't good. These patients can code, so if they do go into cardiac arrest, then you want a team handling the ACLS algorithm, and you want the team handling the malignant hyperthermia algorithm. Muy importante to continue the dantrolene if that occurs, the bipart, the calcium chloride, okay? Really, really important, as well as compressions and everything that you would do with ACLS. Make sense? They're hyperkalemic. They're acidotic and hyperkalemic, that's why they're coding, okay? 707?
That's good.
Beautiful.
Anybody have any questions?
Want to check out the cart? Yeah, check out the cart.
Yeah.
Ask me